Hello everyone, we are here today again finally with Dr. Oleg Akilov, and I hope you missed us a lot because we did miss each other in our small lymphoma talk. And today we will talk about tumor stage of mycosis fungoides, what it is and how to diagnose that. And my first question to Oleg, how often patients will go to tumor stage of mycosis fungoides? They're always so scared with the diagnosis, right? And they are scared with those pictures they see on the internet. How often is that happens?
Thank God it doesn't happen that often. So it's usually less than 15% patients who progress into tumors. And this is a big part of work with those patients. You need to explain that while it's a possibility, hopefully it's not going to happen. But what they need to look for, right, is they need to look if the lesions, in spite of the treatment, getting thicker. Mm-hmm. So this is already kind of like a first sign that disease is going out of control when patches became plaques and plaques became tumors. So this is a slide where we see this classic description, this Oliver-Bazin type that was described as a patch plaque tumors, or even in older times it was like pre-mycotic stage and then patch plaque tumors. Yes, only 15%.
If you see a patient first time with the early MF, can you tell who will progress? And then the second question right away, patients may ask, what can I do? If there is anything I can do in my with my methods at home to prevent the tumor stage?
Well, unfortunately not. Unfortunately, we don't know who's going to progress. There is some risk factors. So that was described recently in publication. That's elderly patients with large skin involvement, more than 10-15%.
Will progress.
Yes, but right now there is no specific biomarkers. We're working on it. So we have some ideas what to look for, but all those biomarker studies still at the level of validation and collecting training and validation cohort. So we're not quite there yet. But I think within the next 2 years, we will have something like tests that exist right now for melanoma, right?
So we can make a little test.
So I think it's coming. But right now we don't.
That would be a very interesting idea to have something similar to what we call calcium test, right? In melanomas that we successfully use in very thin lesions. Okay, and here are some clinical presentations, right? Would you like to talk a little bit?
Sure. So tumors, of course, our disease, the name of our disease came from clinical presentations like this, right? Mycosis means fungus in Greek, and fungoides is also fungus, but of different origin. So it's because these lesions, those tumors, these large infiltrative nodules, looks like mushrooms that you can pick in a forest, right? So dermatology back then was very, very descriptive. So people give names, to stuff that they see around them. So this kind of vaguely reminds them of big mushrooms growing out of people. So everybody knew even back then that this is not normal, right? It's a cancerous process. But what's interesting in this particular presentation is polymorphism of lesions. On a gentleman on the left side, you can see patches and plaques and tumors in the center. On a lady on the right side, patches, plaque not quite clear, but she had maybe somewhere on the thigh, and we have some other pictures too. So this is one of the most important features that I always point out to residents: polymorphism of primary lesions. So you have several different primary morphological lesions in one patient. Not many dermatological entities have polymorphism, and mycosis fungoides is one of them.
That's very helpful, and I think it's also helpful to palpate, to touch those lesions, right? To feel which of them are infiltrating and which of them are not. That's something we are forgetting now, that clinical examination is one of the most important and most useful tests in dermatology, right?
Absolutely. And look, for example, over here. So of course, one exophytic tumor on the chin. Over here, obviously, large infiltrate of neoplastic cells. But to your point, right, palpation is extremely important because sometimes and frequently in those patients, infiltrate goes deep inside. And sometimes it's not obvious and it's not, you cannot appreciate how much neoplastic cells. So you need to touch, you need to gently squeeze it and see how deep infiltrate. Because sometimes there are so-called inverse tumors, especially in patients with follicular tropic MF. And of course, when disease progress or patients not getting appropriate treatment, they develop these disseminated tumors all over. And sometimes we see in those patients that tumors, so it's probably appearance of clonal cells, right, that seeded everywhere in the skin and grow exponentially. But in later stage, it's even tumor within the tumor. So much infiltrate, so much nodularity within one nodule within one element. It's of course, it's very difficult to address. Topicals, of course, not gonna work. We need already systemic therapy, multi-agent, radiation. So,
and it's very impressive. It's of course, it's probably easier if you know the history of pre-existing mycosis fungoides. However, if it's first time when you are seeing a patient, then of course the differential is super wide, and here are some higher magnification pictures, right? So it's really hard to make a diagnosis here when the lesions are isolated.
Yes, and we're gonna talk a little bit more about it later, but over here I want to show. And since there's so much neoplastic tissue, like in the center, you see it's almost like a fracture of the nodules. There's a huge, deep ulceration that can get secondary infected, right? Some lesions that's partially treated, like on the left side, it was radiated, have appearance of deflated balloon, right? But it's still there, and if there's something left, they can regrow over there. So it's created a lot of discomfort for the patient. But maybe in the next slide we can see, so we start talking about differential, pathological differential for those patients. So we already discussed polymorphism, which is very important. So don't forget that back in the past, right, in old times, it was a type of mycosis fungoides that's called Tumor d'emblée type. So it means that it starts immediately, right? Starts without pre-existing patches and plaques. Nowadays, it's not being classified as mycosis fungoides at all. It's being classified as other type of T-cell lymphoma. For example, CD8 aggressive epidermotropic frequently present like this, or there is a PTCL NOS variants. So bottom line, if you have tumors, it's not MF a tumor d'emblée. It's something else.
So you mean if there is no pre-existing history of a patch stage of mycosis fungoides, most likely whatever we see is not mycosis fungoides. However, you know, it's possible that patient was misdiagnosed and maybe he had history of eczema, so you should carefully study his
talk to
history.
patients, certainly do full physical examination, because frequently you can find patches and plaques in those patients. And of course, if patients come and tell you, I had 15 years history of eczema, right? This
so
is
it's
very
most
common.
likely this wasn't really an eczema, or it was an eczema and at some point it was additionally MF. So you know, take all the history with grain and salt. Try to get biopsies if they exist from other physicians done previously, and that will help you. So, but the bottom line, we almost never see mycosis fungoides with purely tumor stage.
And this is another very good example. This lady came with a huge nodule, huge tumor, one single lesion on the shoulder, and that lesion ended up being double positive for CD4, CD8. Cells weren't very large, and we demonstrated that those cells double positive for clonal in the same origin, so it wasn't aberrant expression, it wasn't any admixture of them. But this patient was diagnosed with PTCL NOS.
I see. So even if phenotype could be similar to MF, it's still hard and not right to classify those cases as mycosis fungoides.
So certainly
correct?
These particular cases require a lot of
attention.
Yes, clinical pathological correlation, attention of different specialists, dermatopatologists, pathologists, molecular pathologists, dermatologists, of course.
That's very helpful. So here are some features, right, Oleg, that can indicate that mycosis fungoides is progressing, and some of them are clinical, some of them are histopathological, right?
Yeah, we started already talking about it, right? How we always tell patients to keep an eye if lesions getting thicker. So this is.
And then, do you perform lymph node exam in all your
Absolutely,
MF
yes,
patients?
yes, absolutely. With every single stage, always it's a part of our examination. Spleen, liver, lymph nodes, we always palpate. Usually, of course, MF doesn't go into spleen, liver, but lymph node examination, 100%. Because even if you notice lymph nodes that's more than 1.5 centimeter, by textbook, you have to biopsy it. We don't do it left and right. We usually do imaging first. We usually think if it's going to be therapeutically indicated for us, because sometimes it's not always upstage the patient, especially if lymph node is dermatopathic. Patient will stay in the same group based on presentation in the skin, right? And it's very rarely when you have patient with even excessive plaque involvement and you have lymph node stage 3 by Dutch category, right? Doesn't happen like this. So that's why we're not jumping. But again, we're a specialized center. We know what we're doing. Classically, if you have enlarged lymph node and you see patient first time, you need to biopsy.
And then, do you do regularly blood work in early MF patients or no?
It's also a little bit controversial because there are several publications where they show that some patients do have a little bit of blood involvement, but it's a little bit a tricky business because first of all we have very sensitive tests now, so we can find even one cell by PCR. We can find small little clone over there hanging. Recently, we had a patient who had Sézary syndrome, was treated successfully with mogamulizumab, and flow cytometry was completely negative. Then we did PCR test, and we still were able to trace this original clone that he had a diagnosis. So there's minimal residual disease. How important is this? We don't know. Probably not that important, right? Because flow cytometry completely normal, CBC is completely normal, LDH within normal limits. So it's case by case. It's case by case. It's quite not that aggressive cancer. It's not AML, right? When you absolutely need to put all forces right. Over here, you can sit and wait.
And of course, histopathology can be helpful, right? If you have a patient with MF who had just patch stage and suddenly has new tumors, you still will probably have to biopsy because there could be an additional lymphoma, right? And if a patient has one type of lymphoma, he can have another. And so it's always probably a good idea to do a biopsy. What's your
I would do it for different reason. So usually I'd like to check for large cell transformation because this affects prognosis.
Yeah.
Usually it tells us that treatment needs to be intensified. Because even in some plaques we see large cell transformation. But again, it's a little bit arbitrary feature, right? There is no consensus how many cells. Well, it needs to be more than 25%.
25, yes.
But again, who said so, right? Bernie Ackerman. So it wasn't any correlative studies that show like this is the cutoff. Bernie decided that's going to be 25%, and this is what we run with. So, but some people start saying maybe like clusters of large cells as important as 25%. So there's some features going on around it, right? Some discrepancies. Another interesting point about large cell transformation: tumors frequently has large cells, right?
And that's probably logical because that's already more progressive disease, right?
Exactly.
And then large cell transformation is almost always CD30 positive, but it still can be CD30 negative, and that's the worst, probably maybe a little worse scenario, right?
And we need to be very careful because even some of our residents confused that CD30 for them it's a equal marker of large cell transformation.
No, that's
so
not.
It goes even farther. They take it farther. We're not gonna point to anybody, but some of them think that if they see CD30, it's bad.
Yeah, that's
right?
Not right. That's
and
right.
It's taken because some large cell in MF can be CD30 positive, but CD30 is just a marker, right? Maturation marker on lymphocytes, and present CD30 positive cells in something else not a feature of anything, right? Nodule scabies, widely CD30 positive, right? By arthropod assault, CD30 positive.
Other types of lymphoma.
Yes.
Yeah.
So with even not lymphoma, a lot of reactive processes,
absolutely.
CD30
And
positive.
even drug reactions could be CD30
Yes.
positive.
So be very careful with the CD30 positive, because I cannot tell you how many cases I had. They see CD30 positivity, they think it's at least anaplastic large cell lymphoma or transform MF, and patient doesn't have anything. So CD30, it's totally different story. Don't associate it with anything, right? But in our case, if we're talking about CD30 large cell transformation, prognosis is actually better.
Yeah.
Right.
So large
And
cell
CD30
transformation negative could be negative. That's something that some people forget, and that's actually much worse than CD30 positive.
An idea, I think, behind this is the loss of maturation marker, the differentiation.
Yeah, so
of
basically just morphology of large cells should be called large cell transformation.
If they have tons of mitosis figures, ugly, looking at you, at this point doesn't matter what they stand for. It's bad.
And of course, other CD30 positive neoplasms should be ruled out, like anaplastic large cell lymphoma, especially if you don't have a history of MF, right?
Right.
Have you seen patients with MF and anaplastic large cell lymphoma in one patient?
Yes. Probably it's not the topic of this conversation, because this is where we start kind of sliding into the origin of T-cell lymphomas, the same progenitor, right? Because we had a patient who presented with large ulcerated nodules all over, right? And then ulcerated anaplastic large cell lymphoma without question. He, hit all check marks. And several years later, he presented with LYP, with lymphomatoid papulosis phenotype, and then the same patient presented with just patches plaques.
Yeah.
Which were still lurking a little bit of CD30 positivity, but now it was more classic for mycosis fungoides. So yes, there is a little bit of plasticity over here.
Yeah, so there are some reports in literature how one patient can have different types of lymphomas, and that's amazing, right? And fascinating.
Right, absolutely. So it certainly gives us a lot of ways to explore, to investigate where it's coming from, how can we help. But in this particular presentation, I want to show you that patient presented originally with erythroderma, right? Again, about plasticity of our T-cell lymphoma. And this patient actually had blood involvement and was diagnosed with Sézary syndrome, treated successfully, went into remission for several years, was on bexarotene. But what's happened, she moved to retirement house, and they couldn't give her medication, take care of her, because bexarotene is a tricky drug. It requires a lot of monitoring, adjustment of cholesterol,
other markers,
additional antithyroid medications. So this patient bexarotene was taken away from her, and she progressed rapidly. She developed tumors, right? Those micro nodules all over her back, and it was CD30 positive large cell transformation, and she expired very quickly after it. So disease is real, right? Pathomorphosis is real, and we need to be attentive. So tumors never good.
Yeah.
Tumors always a sign that you need to jump on a patient.
What are the treatments that are in our armamentarium?
So thank God we have quite a few medications that work very nicely, and we can show a couple examples over here. I like pralatrexate. It treats exceptionally fast and clears tumor. Maybe too fast, because some of them can get necrotized rapidly, ulcerate, get secondary infection, especially if it's in a place, in groin, perianal area, axilla. Hard to take care of ulcerated lesion, hard to keep it clean, right? So it's become a source of open infection, sepsis. So this particular patient was treated with pralatrexate. Let's show next slide.
Okay.
And only after, this is his biopsy. And only after
is this the same patient?
The same patient.
That's amazing.
Yes, after 3 infusions, he got completely cleared. So radiation works, total body skin radiation works. So sometimes it's, it's bounced back rapidly. Doxorubicin works, gemcitabine. Pralatrexate, I like it. I like combination of pralatrexate and romidepsin, it's a HDAC inhibitor. So there's stuff. There is a lot of stuff you can do. It
And
depends
are you
on...
doing it alone or in a team of oncologists?
Well, in this institution, I'm doing it alone. It's just happened this way. But in many institutions, there is a collaboration. There's collaboration with oncologists.
Okay. I think we covered a lot of questions about tumor stage of mycosis fungoides, and you always can comment if you have any questions, and maybe next time we can talk a little bit more about some other types of lymphomas, and if you will have any suggestions, would be very nice for us to know what are your wishes. Thank you.